Healthy India Alliance is a coalition of 25 civil society organizations. On behalf of Healthy India Alliance and Sipher, I welcome you all to this consultation. This consultation aims to accelerate efforts for embedding meaningful involvement of people living with NCDs within Punjab's NCD and Universal Health Coverage Action Plans. This consultation will highlight the opportunities of meaningful involvement of people living with NCDs and civil society organizations, draft guidelines on meaningfully involving people living with non-communicable diseases and civil society organization in Punjab's NCD and Universal Health Coverage Action Plans, jointly developed by HIA and Sipher, will be released in this consultation. First, I would like to invite Mr. Arun Verma. Sir, excuse me, slides are not moving. I would like to invite Mr. Arun Verma, Director Finance and Operations Sipher, to give his opening remarks and introduce all the participants of today's consultation. Please, sir.
Thank you, Dr. Varsa. Good morning to everyone. I am Arun Verma. Well, about the today's consultation, the stage for today's consultation was set way back in 2021-22 when HIA and Sipher took the first step seeking to advance the need for a people-centered national NCD response within universal health and the COVID-19 context. To achieve this, they undertook key stakeholders dialogues and conducted a virtual consultation that fed into the development of the state-level report on accessing digital healthcare services during COVID-19 in Punjab. The report was released by the then State Health Minister on World Health Day 2022. One of the recommendations of the report was to develop a state-level multi-sectoral working group comprising of the government representative, people living with NCDs, civil society organizations, doctors, and academia. The working group NCD and universal health coverage is meant to harness partnership to work towards the NCD mitigations. To take forward the extensive work done by the HIA and Sipher, today's consultation would revolve around the efforts and involvement required to accelerate the meaningful involvement of people living with NCD within the Punjab NCD and USC action plan through dissemination and release of the guidelines on the meaningful involvement of the people living with NCD and civil society organizations, along with the recommendations for implementation of the guidelines in the Punjab. A detailed overview on the guidelines will be presented by Dr. Sipher, HIA representative and senior program manager as the consultation goes into the progress. It is a matter of great satisfaction and pride that today's consultation has participation from key stakeholders. To name them, the government representatives from Punjab and Himachal state, NGO state and international, people living with NCDs, medical fraternity, civil society organization, and education institute. To name the few, we have with us Dr. Sandeep Gill is a state nodal officer, National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke, known as NCDs. We have with us Dr. Gopal Chauhan. He is a State Program Officer, NCD and Palliative Care, Himachal Pradesh. He will be joining us on Zoom from the remote as he couldn't reach here on time. We were supposed to have with us Dr. Rana Jay Singh. He is a Regional Director in the International Union, Southeast Asia, but due to some unfortunate incidents, he couldn't join us. Then we have with us Dr. Rakesh Gupta, who is a Director Sipher, as well as he was a former DHS, Director Health Services Punjab. Dr. Shikha Wasim, HIA representative and senior program manager. We have Dr. Basra from the HIA, who is our host today. Now, out of the people living with the non-communicable diseases, we will be having with us Dr. R.D. Waveja, who will be reaching shortly, Ms. Mansi, and Mrs. Mangat Daman, who is here with us. From the medical fraternity, we have a long list of who are to join with us, but some of them are unable to join physically. They will be coming on Zoom with us. Dr. S.K. Mathur, who is an endocrinologist, he will be on Zoom with us. Dr. Anand Gupta, he is an oral oncolo surgeon from Government Medical College and Hospital. Dr. SSOD, cardiologist, a very popular cardiologist of the city. Dr. S.K. Gupta, pulmonologist. Professor Sonu Goyal, who is from Department of Community Medicine and School of Public Health, PJMER. And Dr. Kirat Sibia, MD, Pulmonary Medicines. Dr. Ravinder Khewal is a professor, School of Public Health. From the civil society organizations, we are having with us Ms. Renu Sehgal from Sahitya, Dr. D.P. Surela Senaya, he is present here. Ms. Upinder Kaur, she has already joined from Generation Saver Association, and Mr. Rajiv Chaudhary from the RCTC, Department of Community Medicine, PJ, Chandigarh. We also have representation and from the education institutes, the Tribune School, Ms. Vandana Saxena, Principal. Very nice to join us, ma'am. Ms. Nikita Divedi, Special Educator, and students Kashish and Aditi. As we progress on this consultation and consultation come towards the end, we will be releasing guidelines on the meaningful involving people living with NCD and civil society organization in Punjab, NCD and universal health coverage action plans. Before I request Dr. Versa to take this consultation forward, I would like to introduce very briefly about the Sipher to all the guests available here. Strategic Institute of Public Health Education Research, Sipher, was established in 2018 with the fundamental purpose of creating a specialized public health workforce that can plan, execute, and monitor national health program and public health initiatives for taking, for tackling emerging public health challenges. We are working on all public health issues with a special focus on non-communicable diseases. In the last 43 months, we have organized more than 80 physical as well as virtual workshops, consultations on various subjects in collaboration with the Department of Community Medicine and School of Public Health, PGIMER, Chandigarh, the Union Against Tuberculosis and Lung Diseases, Southeast Asia, many other academic institutes, CSOs. Sipher has also executed short-term projects with WHO and Hridaya, Healthy India Alliance. Sipher also has a YouTube channel by the name of Sipher Health News. We have already recorded informal talks with Padma Bhushan Dr. K. Srinath Reddy, Dr. P.C. Gupta, Dr. Meera Agi, Professor Dr. Sonu Goyal, Padma Shri Professor Amod Gupta, Professor Pratima Murthy, Ms. Preeti Sudan, former Secretary to Government of India, Ministry of Health and Family Welfare, Ms. Vinny Mahajan, former Chief Secretary, Punjab, Padma Bhushan Dr. N.K. Ganguly, former Director Professor Jagat Singh of PGI, Professor Dr. Mahesh Verma, Padma Shri awarded Vice Chancellor Guru Gobind Singh, Indraprasth University, New Delhi, Padma Bhushan Dr. K.K. Talwar, a former Director of PJMER, Chandigarh, Dr. Jagdish Kaur, Regional Director, TFI WHO, SCA Office, and Dr. Joanna Cohen, Director, IGT, Johnson School of Public Health, Baltimore, US. The primary intention is to motivate the young clinician and public health specialists. We are also sharing these videos with the national and international participants to IPH MDP courses being organized by the Department of Community Medicine and School of Public Health, PJ, Chandigarh. Now over to Dr. Versa. Thank you so much.
Thank you so much, sir, for introducing all our eminent representatives over here. And thank you for giving a brief description about Sipher. Next, I would like to show a video of Ms. Radhika Srivastav. Ms. Radhika Srivastav is Senior Director, Hridaya. She is leading the Secretariat of Healthy India Alliance that fosters engagement of multi-sectoral CSOs to address NCDs through meaningful engagement of CSOs, people living with NCDs, and young people. She will share HIA's experience in accelerating efforts for embedding meaningful involvement of people living with NCDs.
Good morning. My name is Radhika Srivastav. I'm the Senior Director of Hriday, which is the Secretariat of the Healthy India Alliance. The Healthy India Alliance is delighted to organize this first state level consultation on NCDs and universal health coverage in the state of Punjab in collaboration with the state HIA partner, Sipher. My apologies that I have not been able to make it to Chandigarh in person for this meeting. I had another meeting which is scheduled in Bhubaneswar, and I needed to travel for that. So, my sincere apologies for not being able to be with you in person. My presentation today is on accelerating efforts for embedding meaningful involvement of people living with NCDs in NCD and UHC action plans, the experience of the Healthy India Alliance. The Healthy India Alliance is a coalition of 25 organizations from across the country who are engaged in multi-sectoral and multi-stakeholder action on NCD prevention and control. The Alliance aims to catalyze multi-sectoral action to enhance health and quality of life in India and to create an enabling environment for active participation of health and non-health civil society organizations to prevent and control NCDs through effective policies, partnerships, and programs. What you see on screen are the list of these organizations who are spread across the country, who have been working tirelessly since 2015 on HIA's endeavor to meaningfully involve civil society organizations, communities, and people living with NCDs. So, to talk about HIA's journey, first let us talk about people living with NCDs. We've always heard the term patients, Maries, Rogi. These are labels which don't go very well with the spirit of community participation. And so, the first thing we did when we started this work way back in the year 2017 was that we coined the term people living with NCDs. Now, this is a term which was coined by the Global NCD Alliance, but embraced by NCD alliances all over the globe and even in India. People living with NCDs are those people who either themselves physically live with one or more non communicable disease conditions or their immediate care providers. When we started this journey of engaging with people living with NCDs or people with lived experience, as we sometimes call them, we initiated community conversations in 3 regions of the country where we engaged close to 50 people living with NCDs to really try and understand what were their needs, priorities, and where did they see themselves in the whole pathway of NCD prevention and control. And through these community conversations, which we did again in various regions, as I mentioned, we organized regional consultations which were planned and led by people living with NCDs, where we put their perspectives at the front and center. We evolved an approach which was called From Patients to Partners, wherein people who live with NCDs are not merely a part of the middle or part of the bottom layer of the hierarchy in terms of they being directed by the medical fraternity on what to do, what treatment regimes to follow. But we reiterated the fact that they also have a stake in understanding the treatment regimes and what are the factors, very importantly, which are inhibitors or barriers in their health seeking behaviors, and how can those be overcome. And so essentially we looked at a two-way approach of how the health system can benefit from the expertise of people with lived experience, and on the other hand, how can people living with lived experience more effectively utilize the services that are available in their vicinity. One very important aspect which came into the forefront was the dearth of capacity among people living with NCDs to articulate their demands as leaders, as champions. When we used to speak to them in small groups, they found those to be safe spaces where they could talk about their challenges, their issues, and they could very confidently voice their demands, their needs, and their aspirations. However, there was a need felt to build their leadership and communication skills to be able to empower them to talk more effectively with communities in and around where they were living, talk to their local healthcare providers, talk to policymakers, and even for that matter, talk to the media in terms of people living with NCD advocates. And so there were a multitude of capacity building initiatives at the global, national, and subnational level that were organized in the country in 2019. Now, this was really before the COVID pandemic struck. So I recall that it was actually the end of 2019 when all this work was garnering momentum. And of course, in early 2020, from March, we all know that there was COVID had it was declared a pandemic, and there were lockdowns. And while this was a huge blow to the treatment regimes of people living with NCDs, there were several challenges that they faced. There were civil society partners and NGOs who worked relentlessly, of course, with the government to take care of the people living with NCDs. But it also gave us an opportunity to understand what their true potential was and how people living with NCDs actually took charge not only of their own health, but also took charge of the health of their family members and communities. And while COVID is a huge assault on the public healthcare system, but it was also an opportunity to fully understand how important it is to engage people with lived experience and people living in communities in decisions and discussions around their own health. We carried the momentum forward, and this is when we started looking at resources that can be developed and started channelizing the potential of people living with NCDs in the overall NCD prevention and control action agendas, both at the national as well as subnational level. What you see on screen is a situational analysis report that we had released in 2021. This was after the pandemic, which really spoke about the challenges and what are the priorities and what are the demands, and how can people living with NCDs actually work in tandem with the government and with civil society partners to really amp up NCD prevention and control efforts. The India Advocacy Agenda for People Living with NCDs, again, was a blueprint which articulated these demands very effectively, and I will be speaking about that later as well. And then the work that we did in Punjab and in the state of Maharashtra, this is where our association with Sipher in Punjab really started, where we developed this Accessing Digital Healthcare Services report. We did a virtual consultation and understood what are the telemedicine requirements, what are the challenges, and what are opportunities. And I'm sure Dr. Gupta will be speaking more in detail about the work undertaken in Punjab. Coming back to the India Advocacy Agenda of People living with NCDs, it has four principles. One is that the rights of people living with NCDs, it's a human rights and social justice issue. So it's not just an health issue. Prevention definitely needs to be prioritized, and so does treatment, care, and support. And the most important pillar was meaningfully engaging people living with NCDs, and not just tokenistic participation where they are brought to meetings to interact with policymakers and be there as a a symbolic figure and say, please implement so and so a policy, or please implement such and such program, because see, these are people living with such and such condition who are impacted. So the full focus was on meaningfully involving them right from the conceptualization to the implementation of the various civil society and government initiatives. We also tried to build a public narrative around the significance of meaningful involvement, and published op-eds in the Hindustan Times, which were also, focusing on why is it important to meaningfully engage people living with NCDs. We even reached the Indian Medical Parliamentarians Forum, where an abridged version of this op-ed was published in the IMPF newsletter. These are available on the links that you see on your screen if you would wish to read them. So what have been our key learnings over the last 4 to 5 years? I would summarize them into these key pointers, which have really informed the work that we have done in Punjab. We came to Sipher with this history and this background, and started from scratch, worked very closely with civil society partners, worked very, very closely with the state government, with people living with NCDs, and even the medical fraternity and youth. And just the key learnings and takeaways that we had. So it's important to transition from a patient approach to a person or a people approach. We must look beyond awareness towards engagement and empowerment. There needs to be focus on a people-led approach rather than a people-centric approach, because these strategies need to emerge out of the communities rather than external stakeholders telling the communities what is right for them. It has to be a two-way process. Meaningful engagement is at a nascent stage. There needs to be more cohesion among patient groups across conditions, and that's a challenge that we acknowledge, and we are trying to look at strategies of how to find a common agenda, because we do realize that each NCD, whether it is cancer, cardiovascular diseases, diabetes, or even mental health conditions, chronic respiratory diseases, have their own sets of treatment regimes, challenges, but then they are all, governed by risk factors, common policies which can have prevention effects on both. So there has to be a common platform where stakeholders who work on different NCDs work and act through a common integrated approach. There need to be specific strategies required to engage people with mental health conditions. Many a times mental health gets sidetracked and sidelined, and it should be the number one priority when it comes to NCDs. There is an important need to generate capacity building opportunities for people living with NCDs. A participatory approach has to be adopted so that the expertise of people with lived experience can be channelized to the health system and health promotion interventions. The engagement of people living with NCDs should be around community mobilization, community support, and research leadership. Ownership of issues coupled with enhanced opportunities for advocacy, such as the National Multi-Sectoral Action Plan, which calls for a whole of society approach, must be tapped into. And we must implement culturally and contextually appropriate innovative strategies for people living with NCD engagement. And very importantly, we must invest resources, infrastructure, manpower, and funds to embed meaningful involvement of communities and people with lived experience. And so some of these learnings, as I mentioned, you will see a reflection of these when Dr. Gupta talks about the work that has been so wonderfully done in Punjab over the last 1 year, actually more than 1 year actually or so. And my team members are also there to talk more about it. And I must congratulate Sipher, the government of Punjab, and all stakeholders who have been involved in creating a multi-stakeholder working group on NCDs in the state. And I wish the meeting all the best, and I hope to be able to interact with you at a future opportunity. Thank you very much.
Next, I would like to introduce Dr. Gopal Chauhan. Sir is joining us virtually today. Dr. Gopal Chauhan is State Program Officer, NCDs and Palliative Care, Himachal Pradesh. Dr. Chauhan is a technical resource person for NCDs, tobacco control and SDGs. Sir will be sharing with us the experiences, learnings and insights on community engagement from Mukhyamantri Nirog Yojana, integrated digital approach for prevention and control of non-communicable diseases in Himachal Pradesh. So please. Please do.
Yeah, am I audible?
Yes, sir, you're audible.
Okay. Thank you,
so-
Sipher, and all the organizers for giving me the opportunity to speak on NCD prevention and control in Himachal Pradesh. Thank you, Dr. Gupta. As you all know that today is, polling in Himachal Pradesh. And it's really difficult, today to move around. And are you able to hear me properly?
Can we increase the volume? Dr.
Hello?
Can you wait? So now I think you can. Yeah.
Hello?
Yeah. You're audible. You're audible, Dr. Gopal.
Okay. Can you give me the, slide sharing options?
Sure, sir. Yes, sir, you can share your screen now.
Is it visible?
Yes, you can start the slide.
Okay. Are my slides visible?
Yes, sir.
Okay. Thank you. Thank you, Dr. Gupta and the entire Sipher team for giving me the opportunity to speak on NCDs today. Unfortunately, I could not join you in person at Chandigarh because we have the polling today in Himachal Pradesh for the assembly elections. Firstly, in continuation to the previous speaker, I would like to say that now we are clear that, what we need to do, how it can be done, and, possibly, what are the, possible solutions. Just to say that, why NCD prevention and control, we talk about the physical health and economic losses, psychological losses. And then the question is, are we serious? Most of the things we already know that, due to NCDs, there will be
Dr. Gopal, can you make it a slideshow?
Yes, sir.
Slideshow.
Economic losses and psychological losses to the, dear family members and the relatives. My question is, are we serious? Why I'm saying, because we know that NCDs, there are certain risk factors, some prevention strategies, health promotion strategies, and they are, few of them are easily doable. And why we are not implementing those strategies at individual, government, and civil society level is a big question. My question is that, are we really serious? Because if we are serious that, then something can be done. And yes, I hope that as a team working together, we can do a lot. Government of India, as if you see the government perspective, government always launches the programs and we have some policies. If you see about the NCD related issues in India, we have multiple programs. Let us start with the government. We have a NCD program, we have a elderly care program, which is just like the NCD program. Then we have issue-based program like tobacco control program, dialysis program is there, Pradhan Mantri National Dialysis Program. We have a separate vertical program, deafness control program, palliative care, the stroke care program, mental health program, blindness control program, oral health program. There are I think 14 or 15 programs are there, which are related to NCDs. The issue, I think, we know that currently more than 80%, premature mortality in India is due to NCDs. We want that as a developing nation. We have a broader agenda by 2047 that we want to see India as a developed nation. But you see this condition that 80% premature mortality is due to NCDs. But if you see about the qualities and daily losses, that they are huge quantum. There is a huge economic loss in productivity. The problem is when the family members dipped below poverty line because the NCDs are having a chronic long term of duration. Coming to Himachal Pradesh briefly, till 2016 we were thinking that Himachal is a healthy state. We don't have bigger issues of NCDs. But when this report of the Health of the Nations report 2016 by ICMR and Government of India came, then we realized that in Himachal Pradesh,
Dr. Gopal, may I
yes,
let you know that the slides are not moving. Can you make it slideshow from the top?
yes, sir, it is already slideshow, but I will try again, sir.
Yeah, now it is moving. Yeah.
I will try it again. First, I have to do stop share, then again. Is it okay, sir? Is it moving, sir?
Do it again.
Is it moving?
नहीं, एक मिनट टॉप से ना आप स्लाइड शो जहाँ लिखा हुआ है, you can just click on that.
Yes, sir. We have two options. पहले मुझे पहले वाला बंद करना
F5.
है। Yes, sir. Yes.
फंक्शन की 5 करके देख लो F5. चलो नहीं तो ऐसे ही मूव कर दो, doesn't matter. ऐसे मूव कर लो आप.
Is it okay, sir? अब ठीक है सर?
नहीं, अब मूव करो, स्लाइड मूव करो, फिर देखते हैं.
नेक्स्ट
मेरे साइड में ये मूव हो रहा है, बट आई थिंक इट्स नॉट विजिबल टू यू.
और कुछ है तो सही इशू.
एक बार दोबारा ट्राई करता हूँ.
या आप अब अगर हमें भेज दो अपनी ये पावर पॉइंट, सो वी कैन शेयर फ्रॉम अवर एंड.
ओके, मैं इमीडिएटली आपको भेज देता हूँ. भेज दिया.
बरसा की मेल है आपके पास?
नहीं, मैं आपको भेजता हूँ.
अच्छा, मेरे को भेज दो आप. ठीक है, आप मेरे को भेजो, मैं शिखा को करता हूँ. मेल कर दिया आप?
यस सर, आप उसको चेक कर सकते हैं.
किस पे, साइफर पे किया कि दूसरे पे किया आपने?
नहीं सर, आपका जो मेरे पास
पर्सनल पे. ओके,
राकेश 60 वाला है.
हाँ. यू कैन जस्ट कंटिन्यू टू स्पीक, मैं देखता हूँ.
यस सर, मैं वो मेल देखता हूँ. यस सर, मेल तो जा चुका है.
हाँ, कोई बात नहीं. You can continue to talk without slides.
ओके सर, मैं दोबारा इससे भी कोशिश करता हूँ कि यहीं से हो जाए। अब ठीक है सर? Okay. In 2016, when the ICMR report came, then we realized that, in Himachal Pradesh, the NCD toll is very high. And despite of a good economic status of the people, लोग यहाँ पैदल बहुत ज़्यादा चलते हैं, working population है, maximum rural population है. But you see the risk factors and the leading causes of daily ischemic heart disease, COPD, stroke, asthma, and you see malnutrition, hypertension, diabetes. Then we, try to explore the possibilities that how NCDs can be prevented, managed, can something be done. Then we try to implement the Government of India NCD program, which is the NPCDCS, which was launched in 2009-10. It talks about risk reduction, NCD screening, early diagnosis and management of NCDs, rehabilitation in plus 30 population. And in 2016, the screening was shifted from opportunistic screening to population based screening. मैं ये मानता हूं कि अभी भी ये opportunistic ही है, because population based screening ये आशा वर्कर एक फॉर्म के साथ जाती है, वो क्वेश्चन बेस्ड स्क्रीनिंग है, बट एक्चुअल स्क्रीनिंग इज स्टिल इन द इंस्टीट्यूशन. बीपी शुगर मेजरमेंट इज ऑलवेज हैपनिंग एट इंस्टीट्यूशन लेवल, मे बी एट हेल्थ वेलनेस सेंटर और सब सेंटर, पीएससी, सीएससी. बट द कन्वर्शन इज कि पहले उन्हीं लोगों का टेस्ट होता था दोज हु वर विजिटिंग द हेल्थ फैसिलिटीज. नाउ द आशा वर्कर इज गोइंग टू हाउस, वहां पे एक क्वेश्चन है उसके पास, वी कॉल दैट सीबैक. उसमें से रिस्क असेसमेंट करती है और प्रायोरिटाइज करती है कि दोज हु आर टू बी स्क्रीन. देन नाउ हेल्थ वेलनेस सेंटर इज द न्यू फोकल पॉइंट फॉर एनसीडी स्क्रीन. देयर आर सर्टेन लिमिटेशंस ऑफ दिस गवर्नमेंट ऑफ इंडिया प्रोग्राम. नंबर वन, देयर इज अ लैक ऑफ कंटिन्यूम ऑफ केयर. It talks about screening and risk assessment of plus 30 population, but you know that the main risk factor जो NCD के हैं, tobacco, alcohol, unhealthy diet, physical activity, stress, वो ज्यादा 18 to 13 population में आता है. Up to 18 years we have a RBS के program. I am talking about the government perspective कि government के पास क्या क्या planning है. For plus 30 they have a program. For below 18 they have a RBS के program. But there was no focus program for 18 to 30 year population. But major risk factor वहाँ पे आते थे. I talked about multiple programs. They are vertical programs, fragmented approach. It means that HR और economic वो financing अच्छी programs की नहीं हो सकती. There is always resource scarcity. It means that if you start implementing one or two program vertically, attention उधर को divert हो जाता है. Few people talk about only diabetes, other talks about hypertension, somebody talks about mental illnesses. But you see that all NCDs are almost common in nature. Poor monitoring and very low focus on health promotion. सिर्फ उसमें guidelines में लिखा है, but there is no study. In Himachal Pradesh, हमने उसको मिक्स करके we started a new program known as मुख्यमंत्री निरोगी योजना in 2019. A Government of India program is talking about 5 risk factors. We talk about 15 NCD risk factors. They focus mainly on 3 diseases. We focus on all NCDs. वो सिर्फ डायबिटीज, हाइपरटेंशन और 3 कॉमन कैंसर पे फोकस करते हैं. वी टॉक अबाउट मेंटल इलनेसेस, डेफनेस, ब्लाइंडनेस, एपिलेप्सी, स्ट्रोक, ऑल जितना डिजीजेस एनसीडी रिलेटेड, ब्लाइंडनेस. They talk about the NCD clinic and we have integrated neuro clinics. Integrated neuro clinics is a NCD clinic, but वहाँ सारी NCD की सर्विसेज दी जाती हैं. The doctors are trained for that. Government of India has a NCD application. We are having a own health card application जिससे data we used to migrate the data to Government of India application. Because Government of India application is limited to 3 diseases and few risk factors, but now they are trying to expand it. Then the reporting system of Government of India is quite cumbersome. Currently 3 types of report has to be generated by health worker or by CSO. One is health wellness center portal. Data health wellness center portal में भी जाता है. There is a Government of India NCD application. Third one is a manual form 6. In Himachal Pradesh we are having only one form, that is digital. That is connected through API with Government of India application. But Government of India level पे अभी जो हेल्थ वेलनेस सेंटर पोर्टल है उसका इंटीग्रेशन नहीं हुआ एनसीडी एप्लीकेशन के साथ. So it means dual entry होती है, which is health workers CHO, they are वो कह रहे हैं कि please stop this. Government of India is saying that they are trying to integrate. But we have in Himachal Pradesh, we have only digital information system. In Himachal Pradesh, we call it as a continuum of care. We are screening the 18 plus population. We are, all the NCDs, we have a single format, single CBAC form, where we get information for all NCDs collectively. We don't go for this is a mental health checklist, this is a blindness checklist, this is a diabetes checklist, this is a checklist for cancer care. We have only one checklist for all NCDs and all associated risk factors. Integrated approach, then in rural clinics, and the surveillance is only digital. If you see that in Himachal Pradesh, what we do, this is our strategy. How much this strategy is being implemented, that I will come to that later. But we have risk assessment for plus 18 population, risk reduction. Individually, we are doing for certain risk factors, but we have a policy also. Early screening, management for management of NCD, because we know that we are going for active kind of approach for identification of the NCD patients and persons having with family history of NCDs. Then we need to have some mechanism where to address those issues. The curative institution, we have cardiac care unit, cancer care unit, stroke unit, dialysis units, and neuro clinics where we provide NFLD services, COPD services. For follow-up, we have palliative care units and for rehabilitation, palliative care units and follow-up being done through health workers, ASHA workers, and MWOs. This is a pamphlet. This is some sort of IC material which every ASHA worker is giving to individuals of plus 18 population while doing some question-based risk assessment of the individual. Then this is the mobile application. We used to collect this data on mobile application. If you see that we have done risk assessment of 27 lakh people in last 3 years, it would have been 43 lakhs, the entire population, but due to COVID, this was hampered. But now we are able to understand what are our risk factors at state level, district level, block level, and at village level, so that we can address those issues. You can see that unhealthy food intake is 41%, physical inactivity is 32%, passive smoking is 23%. Likewise, all the risk factors. Now coming to the screening. Out of those who are risk, they are sent to the CHO immediately. And we have identified 18 lakh people. More than 11 lakh has been screened for diabetes, hypertension, waist circumference, loss to follow-up, abnormality in oral cavity, abnormality in breast, and likewise. Now we are able to understand that who are the individuals, those who are having high blood pressure, high blood sugar, increased waist circumference, and what are the associated risk factors of that individual. Now coming to the persons, out of 11 lakh people, 4 lakh has been diagnosed by doctor. And out of 4 lakh, this is the proportion of the diseases that 53% people out of 100, they are hypertensive, 28% are diabetic, epilepsy, deafness, mental illnesses, breast cancer, CKD, oral cancer, vision problem, COPD, asthma. This is the, we have the individual wise information, village wise, district wise, and block wise. This becomes very easy for, if we want to do the follow-up. This is the summary that how much percentage we have screened, how much has been sent to doctors, how much are on treatment, how many persons are on follow-up. Currently, we have covered more than 60% population for risk assessment. And out of those who are risk, more than 70% has been sent to screening. And 100% those who are screened has been diagnosed by doctors. And about, I think there are two types of therapy. One is for, what we call treatment. Another is we call patients after 2-3 months, you reduce the salt intake, you do some physical activity, now come again to the institution. This depends upon the doctors and the protocol. For risk reduction, yes, issue-based like tobacco, alcohol, unhealthy diet, physical activity, we are working on those. But most of the things we are covering in the comprehensive health promotion, as Radhika has said. This is nothing but this is the multi-sector action plan implementation in the state of Himachal Pradesh by involving all the key stakeholders, including the individuals. For health promotion, we are having the health promotion education institutions mechanism. We certify the schools based on some checklist. There are committees for that. Those who implement those intervention at school level. They are monitoring committees, and we have started certification of the schools as health promoting education institutions, which covers all the NCDs factors, what they do, how to check the food, how are the habits, and how to promote health in the community. Then we have the protocol of tobacco free education. We have the protocol of tobacco free panchayats. We give 5 lakh award to a panchayat on declaration as a tobacco free panchayat. Now coming to these are the health promotion mechanisms. Few institutions has already been certified as health promoting education institutions. Yes, the most important is management of NCDs, because those people, those who are working on clinical side, they talk very less about health promotion and prevention on risk reduction. They mainly talk about the curative service. If you see that for CBD, we have cardiac care units. We are expanding the STEMI care in Himachal Pradesh. It is working. We have dialysis facility in most of the, I think within 15 kilometers, we find a dialysis unit in Himachal Pradesh as of now. Government of India program is only up to district level, but we have penetrated to the civil hospital level. We are giving chemotherapy at district and sub-district level through MBBS doctors under supervision of the specialist. We have 10 chemotherapy units. Palliative care we have established at 10 locations. We have stroke units at 19 locations, and integrated neuro clinics. It is 10, but we are expanded it to 16. The 16 places which we call as integrated neuro clinics, they will be like a district hospital. There will be comprehensive NCD care package under the supervision of the specialist. Then the mental health unit in all districts. Yes, we have got some rewards and recognitions at national and international level by United Nations also. PM Digital Award, Best State for implementation of the NCD program. But overall, if you see that the comprehensive NCD programs strategies is there, but there are always challenges in implementation. One of the challenge in implementation is the poor monitoring. We are trying to monitor the situation, and I think that by next year we will be able to achieve more than 80% of the digitization of the health record of all individuals in the state. Currently it is 74%, and then the neuro clinic will be functional, and we will be focusing more on control of diabetes and hypertension. Currently it is 41% hypertension control, and 30% is the diabetes control. We want to increase it by next year more than 50% by the end of this year. I think this is our plan in short. Thank you very much for giving me the opportunity. So now,
So thank you, Dr. Gopal, for sharing your personal experience. And I think we all need to follow Himachal Pradesh. They have done a wonderful job in managing non-communicable diseases, and they have even gone beyond the mandate of Government of India. So they are screening 18 plus population instead of 30 plus population. So we have written a letter to I think it was in September, we had a dissemination workshop with Dr. Gopal. Was it September, October? In September. So we wrote a letter to Secretary Health to write to all Principal Secretaries Health to follow what Himachal Pradesh is doing. They have a wonderful app, and they have a real-time data of all kinds of patients, hypertension, diabetes, even renal diseases have been covered, ear diseases and eye diseases, they have been covered. So thank you, Dr. Kapal, for being able to join, and we know it is election day today in Himachal. Still, he was able to join us. So thank you. Thank you.
Thank you, sir. So nice. Thank you.
Thank you so much, sir. Today we have with us Dr. Anand Gupta, oncosurgeon and maxillofacial unit head in charge of Government Medical College and Hospital, Chandigarh. Thank you for joining us today, sir. A warm welcome to Dr. Kirat Sibia. Today, ma'am is here with us. Thank you so much for joining us today, ma'am. We have with us Mrs. Reenu Sehgal, President of Sahayata Charitable Welfare Society. Thank you for joining us today, ma'am. Our next speaker is Dr. Rakesh Gupta.
Dr. Gopal, you can stop sharing the screen, please.
Sorry, still sharing the screen. Dr. Rakesh Gupta is President and Director Sipher. He is the former Director Health Services and Director of Chemical Examiner Lab Punjab. I request Dr. Gupta to introduce the multi-stakeholder working group on NCDs and UHC in Punjab and highlight HIA's and Sipher's work in Punjab. So please.
So we are here to participate in state civil society consultation on NCDs and USCs and accelerating efforts for embedding meaningful involvement of people living with NCDs within Punjab, NCD and universal health coverage action plans. So we have almost all the stakeholders with us, and we are doing this in collaboration with Healthy India Alliance or Hriday, and some sub-national activities in Punjab with the Sipher. So this was a virtual consultation on access to quality healthcare and telemedicine services during COVID. So we organized this workshop in February 2022. So all CSOs were with us, medical fraternity was with us, and we had government representatives including Dr. Sandeep, and we had people living with NCDs with us. So the thematic discussions were, there were challenges and opportunities in harnessing telemedicine services during COVID-19 in the state of Punjab. And we actually, during COVID, we upgraded the telemedicine services to help the people of Punjab, the patients. So we had experience of accessing healthcare and self-management of NCDs during COVID-19. And there were lessons learned from virtual and in-person healthcare delivery for NCDs during COVID-19. And the role of CSOs has been utilized in enhancing meaningful involvement of people living with NCDs. So this was the brochure we actually produced after the workshop regarding accessing digital health services. So the findings from stakeholder dialogues and virtual consultation fed into the sub-national report on accessing digital health services during COVID-19 by people living with non-communicable diseases. So these are the experiences from Punjab. So the recommendations from the report were that capacity building has to be done at sub-national level for people living with NCDs. State-level multi-sectorial working group has to be constituted, comprising of people living with NCDs, civil society organizations, doctors, academia, and the government of Punjab. So we have already formed a working group, and most of the members of the working group are with us now, either through Zoom or physically they are present. So we had also to develop state-level guidelines for meaningful involvement of people living with NCDs and CSOs for NCD prevention. So today we will be releasing these guidelines. So you all will be releasing the guidelines. So technology as an integral part of the current and future health system strengthening and needs to be tapped into appropriately. So you have already seen that how much technology now, even the government of India, government of Punjab, they are utilizing for managing all kinds of diseases, including NCDs. And to provide easier and more accessible telemedicine options, as well as train and provide support to the people living with NCDs for self-management and digital literacy. So earlier what was happening was that it was not centric to the people living with NCDs. So they were not involved in the management and planning of the NCDs. So now our aim is to involve them properly so that they are part of the team. So CSOs may be involved towards strengthening of telemedicine services in the state, as well as capacity building of community health officers. Then community engagement involving civil society and people most effective and at risk is fundamental to effective health responses. So I think this is all I have to say, and now we'll have Shikha. So she'll be talking about the guidelines. So Shikha, you're welcome.
Our next speaker is Dr. Shikha Bhasin, Health India Alliance representative and Senior Program Manager Hriday. Dr. Bhasin will provide an overview of guidelines on meaningfully involving people living with NCDs and civil society organization in Punjab's NCD and UHC action plans.
Hi, good afternoon, everyone. Dr. Gupta has already set the context for where this work has led to, and Radhika has also set the context that we as the Healthy India Alliance, we've tried to bring together CSOs that work in different spaces within the NCD sector and also meaningfully involve those with lived experiences. So I will take it forward from here. So along with Sipher, we came up with these guidelines on meaningfully involving people living with non-communicable diseases and civil society organization in Punjab's NCD and Universal Health Coverage Action Plans. This came from the recommendations of our report. And basically, it's meant to harness partnerships towards NCD mitigation and treatment strategies. So in August 2022, we had the first meeting of our working group where deliberations on these guidelines were done to make sure it's holistic and it includes everyone's views. So this is again the genesis, as I just stated, that these are what our aims are, and they've been developed by these partners. Our partners, people living with non-communicable diseases, CSOs, and medical professionals. So firstly, how would you actually define people with lived experiences and civil society organizations? Because they both form very important elements of community engagement. So people living with, they also encompass their caregivers, those who are survivors. And although the main NCDs which are covered are cancer, cardiovascular diseases, chronic respiratory diseases, diabetes, and mental health, there are a range of other conditions that do come within the gamut of NCDs. Civil society organizations are most non-governmental organizations, including academia, research, institutes, policies, think tanks, the likes. So now I will move on to, okay, sorry. So basically, why is it important to actually meaningfully engage both of these sectors? Basically, if we bring the voices to the table of people with lived experiences in decision making and accountability processes, we would be able to understand what their priorities are, because we're putting in all of these programs in place for them. So we do need to tailor it according to what their needs are. And this would also be in the larger agenda towards a move towards universal health coverage. And also it entails a leadership role and an active involvement in all aspects of NCD response. That would include governance, it would include policy formulation, enforcement, design and delivery of programs, and community mobilization, evidence generation, and impact evaluation as well. So when we are able to tap into the unique first-hand insights and the expertise of the kind of contextual challenges that are there within NCD prevention and treatment, and overall ensuring a better quality of life for those with lived experiences, we could have a stronger response towards NCD prevention and treatment. Why do we need to include civil society organizations? So CSOs, they form that bridge, especially to the most vulnerable populations, say the kind of people who can't be in this room right now. So they have the capacity to reach out to these marginalized sections, and they also provide additional human resources as well. They can ensure that there is meaningful involvement of those with NCDs and young people, given that we also have young people in the room today, in all parts of NCD response and commitment by building the capacities as well. CSOs also have the ability to draw from the expertise to inform processes on health planning and program implementation, as well as undertake research and evaluation of NCD programs. So these are the guidelines that we came up with. They're shortened here, but I will explain them a bit more in detail. So we made different guidelines for different stakeholders. We made guidelines for our working group on what they can lead and take forward. We made guidelines for CSOs, and we made guidelines for people living with non-communicable diseases. So the guidelines for our working group, what we put forward was that our working group, they could promote an NCD's communication strategy on how they could utilize the IEC budget which comes under the NHN or NPCDCS, so that in addition to health messages which can go out on social media and stories in print and electronic media, that would lead towards an increased understanding about NCDs and increased awareness. We also put forth that the working group can engage in regular discussions and monitoring at the state level, in civil society conferences, and in districts in the district health society meetings to support development and implementation of the NCD policy and practice in Punjab. This working group could also provide comprehensive partner support packages for people with lived experiences by incorporating their views of subject experts in the working group and convening them to grassroots health workers, for example, in the Aam Aadmi clinics, the CHCs, PHCs, and the health and wellness centers, for example. It can also deep dive into understanding what are the actual needs and priorities of those with lived experiences through conducting community conversations or focus group discussions. And similar to the advocacy agenda that has been put forward at a national level, a state level advocacy agenda can be tailored, which voices the priorities and needs particular to the state. They can also work towards addressing issues of stigma and discrimination to promote increased respect and acknowledging the lived experience of those living with NCDs, moving them from being viewed as just patients to partners in healthcare decisions. They may also draw from the rich experience of members from different backgrounds to develop and lead prevention campaigns towards risk mitigation that can be tailored as per different stakeholders which are available. They can also work towards identifying which are the different ministries and the departments within the ministries that could possibly be included in NCD prevention and control strategies, such as including youth affairs and sports to emphasize on physical activities and education to spread awareness on the prevention and control of NCDs and its risk factors starting from a younger age. Another thing that the working group can do is they could cull out case studies from other states, such as how we had Dr. Chauhan present right now, and other such initiatives such as Happy Streets from Tamil Nadu, which can be brought to the table and actually put forth to policymakers as best practices that could be replicated. Then we have guidelines which are for CSOs, which are involved in our working group and even beyond. So capacity building of the CSOs could be carried out at a state level to implement screening, awareness, access, and policy focused activities under the National Multi-Sectoral Action Plan, which is up for renewal in 2022. CSOs can also develop and disseminate contextually appropriate, person-centered, evidence-based campaigns and knowledge products. Providing this information and educational materials could help mobilize people living with non-communicable diseases to put forth their needs and priorities. CSOs can also contribute to areas of health promotion, including social behavioral change communication strategies that can be designed, implemented, and evaluated with scientific rigor, given the expertise that they have. And this can help creating a supportive environment, strengthening community actions, developing personal skills, and reorienting health services. So HIA has done something similar at the Southeast Asia level with WHO, where we did capacity building of those with lived experience so that they could actually go and advocate to their governments on what their needs and priorities are. And that is something that can trickle down to a state level as well. So CSOs can also make further efforts to amplify the voices of those living with NCDs and their caregivers. And they can also undertake accountability assessments from time to time, such as developing and using of shadow reports, benchmarking reports, which could be submitted to the government to increase accountability. This would also help in aiding the monitoring processes and identifying any gaps in the implementation of these programs. The CSOs can also ensure that people with lived experiences are actually brought to the forefront of the programs. And this actually links back to those that if you undertake capacity building activities with them, people living with NCD champions can actually be brought into policy discussions as well. And that also includes involving your self-help groups and also seeing that how could you actually ensure that they take charge of their health and transfer their learnings and best practices to others. So within our HIA network, we have a number of organizations which are led and consist of people with lived experiences. Most of them are around diabetes, but they do very good work in bringing to the forefront what their needs and priorities are. And similar initiatives could be done across the board for other non-communicable diseases. CSOs can also engage and empower with youth for NCD prevention and control, and extend health promotion messages and activities to the community level, given that there are a number of CSOs that do work with schools towards school health programs. This is a good source that can be tapped into, where youth-led campaigns can be designed and implemented. They can also contribute towards evidence building and strengthening of community health interventions as well. We also put forth guidelines for people with lived experiences. So again, capacity building of people with lived experiences, if it's carried out on communication and leadership skills, it could place them as decision makers in shaping their individual and community health agendas. If they're provided these central roles in government and civil society initiatives, their experience and expertise can be tapped into to inform multi-stakeholder and multi-sectoral interventions to address NCDs and further to achieve universal health coverage. Meaningfully engaging with and supporting people with lived experiences can lead to development, implementation, and monitoring of progress of the programs, such as the NCDs programs, and also to actually leverage other NCD platforms and networks, say connecting with further NGOs, connecting even to, say, data collection mechanisms which are needed for health. And this engagement has to be included and supported by other sub-national level strategies and policies, and also be provided budgets for the same. And one very important point, because we've been working with AIMS Delhi, and especially when you're dealing with people with lived experience with lesser education levels and lesser awareness, is a lot of times there are a lot of myths surrounding their conditions. There's a lot of fear in speaking to the doctors. So people with lived experiences, they do have to be involved by their doctors to be able to share their experiences, to be able to share what any doubts they have. And for this, we've actually also been doing capacity building with the residents, junior residents at AIMS, on how to approach people-centric care. And that's something that it's best if it's led by people who live with non-communicable diseases, because rather than, say, me coming from a CSO perspective, I can train a person living with to be able to express themselves better, but they are the right people to actually showcase how people-centric care should be taken going forward. So that is the last recommendation that we have in place, and thank you so much. I hope we can take this forward, and because I think the basis for achieving universal health coverage is to ensure that care is designed and led by the people it's meant for. So thank you.
We'll be giving a copy of the guidelines to you.
Yes, we will be releasing the guidelines later, and everyone will have a copy. Yes. Yes, yes. Yes, we can.
Okay, we'll see if he's able to join again. So I think after the... okay, okay. Okay, okay. 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 So, after Sandeep, if we are able to take him back, we can ask him. So after Dr. Sandeep. Thank you.
I would like to welcome our next speaker, Dr. Sandeep Gill, State Nodal Officer, NCDs Punjab. Dr. Gill has 25 years of experience in primary, secondary public health care. Dr. Gill will be sharing his insights on NCDs role in control and prevention of major NCDs in the past few years in Punjab, and how multi-stakeholder engagement is necessary for NCD prevention and care. So please.
Good afternoon, all. Thank you for calling me for this webinar, hybrid webinar on physical and virtual mode. First of all, congratulations to the Sipher team and Heride for organizing this consultative webinar on, especially on the NCDs with the focus on people living with NCDs. I'm State Nodal Officer for NCDs program. That's a national program for prevention and control of cancer, diabetes, cardiovascular disorders, and stroke. I look after some other programs also along. I look after elderly program. I look after mental health program for the state. I look after a state program called Mukhyamantri Punjab Cancer Rahat Kosh. Some other small programs, rare disease policy, free diagnostic initiative. So, to start with, I think it's been more than 20 years we have been talking only much about NCDs. Globally, if we see, WHO was aware there is a transition of disease burden from communicable to non-communicable. And by 2000, there was an alarm to tackle this transition where the 70% of the disease burden is of non-communicable diseases now. At the national level, some workshops and seminars were done, and I was fortunate that in 2003, I was part of one of the initial workshops which was done in the region in PGI Chandigarh. And we listed, we tried to make a district pilot project for NCDs. And we listed about 10-15 NCDs of concern. It took another 7-8 years before the national program for prevention and control of cancer, diabetes, cardiovascular diseases, and stroke came into picture in 2010 and 11. In Punjab, we had Bathinda as our pilot, first district to be adopting this program. And subsequently, in coming years, we added on 5 districts. And by 16-17, we had all Punjab covered with this flagship program of NCDs called NCDs. So we started working on it vigorously. By 2019, we did all the training programs in the state. Unfortunately, the COVID came, and 20 and 21, when the program started rolling, and it was obstructed by COVID. Before I move ahead, because it takes 20 years to start things working, the pace is very slow. But pandemic of this non-communicable disease is much fast. If there are 10 dengue deaths, it's a headline today in the newspapers for the state of Punjab. And it is a pressure on the political leadership. But there is no concern that we have one of the highest prevalence of hypertension in the country, in the state of Punjab, along with Telangana, of course, and some other states. We have 34% of prevalence of hypertension. It's one of the main challenges, and cardiovascular disorders are the main concern in the NCDs. People living with NCDs. We had started a special program. It's a state-specific and running in Karnataka and in Punjab only. It's called Care Companion Program. We had started educating our patients for MCH services in 2018-19 onwards with this program, where the staff nurses in the healthcare facilities would educate the patient about how to give they were educated how to deal with breastfeeding, the wound care, about all that, about the surgical and medical advices, and along with to their relatives who were there in the wards. So staff nurses were given flip cards. They were given some education material which they would show it to the patient with the pictures, and that was a good initiative. Recently, we are going to do it for NCDs now. We have trained staff nurses at the SDH level also, sub-divisional hospital level also, and district hospital also. So all the 41 sub-divisional hospitals of the state will be giving this service. It will be starting by 17th of November itself, where we'll be educating all the people who are coming to the hospital about the NCDs with these pictorial flip cards, and we'll be distributing educational material also. And we will be releasing, there is a mobile teleconsultative helpline, you can say, or you can say it's a number where you can call and you will be guided and educated for NCDs. So, before that, I'd like to touch upon a multi-sectoral approach for NCDs. We did a workshop with Punjab University and PGI team some months back. It's been time now for involving all the departments for tackling, because health department itself cannot take this. The burden is too big. 30 plus population we have to cover in the state as per by the program. I'm happy Dr. Gopal is doing 18 plus population for his state. They have done good in the state. But we are following as of now 30 plus population to be screened. Unless we don't know who is having, how much is the prevalence, exact figures, we will not be able to tackle it. We did this workshop. We intend to involve, like, the sports department, because NCDs are originated by the lifestyle. Lifestyle diseases have to be tackled at the root where they start from. So, sports department, where we want to increase the physical activity with the students, with the youth, with everyone, Education department, to catch the young minds there itself, to educate them about the NCDs. I know many of the schools, they have this educative programs where they teach children not to eat junk foods. But the menace is so much. Most of the children are eating junk food, even if they have taught that, and they're celebrating their birthdays in one of the McDonald's or these restaurants where they take along their schoolmates, and that's become a fashion. That is leading to an increasing trend of obesity also. So we are to involve education department, sports department. We have to increase taxes on processed food. We have to increase cess on tobacco. We have to increase cess on alcohol. So we have to involve excise and taxation department. We are all aware that salt is harmful. We have one day called Salt-Free Day in the calendar of health calendar. It's in March. But despite being aware, people not practice, what they are taught. Most of the things we talk about, they all are known to people, that medication has to be regular, but still they don't follow that. So, excise department, there are numerous departments which we like to involve panchayat department to reach to the village level for awareness. I was sharing with one of the directors of panchayat department. He said they have WhatsApp groups where they can send the audio video clips, for education and awareness. So this activity will be on with us, we intend to do it. Multi-sectoral approach will be there, and the state is looking forward to that. What we do here at the moment for the state, for NCDs, is with this flagship program, PCDCS, we are only tackling, the four main components of NCDs. That's cancer, diabetes, cardiovascular disorders, and stroke. While the WHO says that the COPD is also main primary NCD, which is to be tackled because it counts for about 11% of the disease burden amongst the NCDs. We are doing two type of screening process. One we call population-based screening, and other is opportunistic screening. Opportunistic screening, we do it all healthcare facilities. And population-based screening, we do it at the village level, at the community level, where our CHOs and the ANMs and ASHAs as a team, they do screen people for diabetes. Then they measure their glucose, they measure their blood pressure, and they check for three common cancers. That's oral, breast, and cervical cancer. Starting with the cardiovascular component of this program, in the state we have two special projects running because the hypertension prevalence is much more. So we have India Hypertension Control Initiative. It's the WHO ICMR project, and we are having good results. We started with this project, with 5 districts, and last year we added another 5 districts. So we, out of 23, we are having 10 districts covered under it. We intend to expand in coming days, in coming months we'll be expanding it to few more districts. So with this project, there is a dedicated teams, and what's the best outcome out of this is that what we call treatment compliance. Usually patients with diabetes and hypertension, they don't follow their regular treatment. अगर मैं पंजाबी च कहां कि ਉਹ ਇਸ ਤਰ੍ਹਾਂ ਕਹਿੰਦੇ ਹੈਗੇ ਕਿ ਅੱਜ ਮੇਰਾ ਸਿਰ ਦੁਖ ਰਿਹਾ, ਮੈਨੂੰ ਲੱਗਦਾ ਮੇਰਾ ਬਲੱਡ ਪ੍ਰੈਸ਼ਰ ਵਧਿਆ ਹੋਇਆ ਹੈਗਾ, ਜਾਂ ਅੱਜ ਮੈਨੂੰ ਲੱਗ ਰਿਹਾ ਕਿ ਮੇਰੀ ਸ਼ੂਗਰ ਵਧੀ ਹੋਈ ਹੈ. So this is the common, when I interact with patients, so this is how they treat themselves, and then they pop in the pill and then they settle it with that way. They are not regular on their treatment. So this IHCI program has brought a treatment compliance for the hypertension patient, which is to the tune of 61% at present. That means out of 100 patients enrolled in this program, 60 patients are regularly taking their medication because these teams, they monitor and follow the patients.
Dr. Sandeep, please, can we continue afterwards because there are 3 people who need to leave.
All right. I'll cut it short itself. I'll take another 5 minutes.
We can continue.
In fact, I have to also leave. I'll cut it short. And then we have another project called STEMI project, which is also in a state of Himachal. They're doing wonderful with it. ST elevation MI. So we have at present, running in 8 districts. We started as a pilot with Ludhiana and Patiala, and now we added 6 more to it. Recently, we added district Malerkotla. It's a newly formed district, and we added that. So this is again because these two STEMI, why we have STEMI is because the irregular treatment of or the uncontrolled hypertension leads to either a heart attack. 90% of cases will be either a heart attack or a stroke. So this project was needed. I'll not go into details of the project. And under the cancer care program, the component, we have 2 projects going on. One is in collaboration with Clinton Health Access Initiative, and another one is with, we recently joined for in hands with Niramai, a startup company in Bangalore for breast cancer screening. We are the first in the country to start breast cancer screening with the artificial intelligence-based, digital technology. It's infrared-based technology. It's not X-rays. It's not a mammogram. We're going to do it at pilot for 15,000. And then cost of a mammogram usually is around 1,000 rupees. Ji. Yeah, this is, we made a deal with them, and this is coming to 130 rupees approximately per screening. We are doing it in Punjab. We are covering all the district hospitals, all the sub-divisional hospitals, and selected community health center where this team goes. And there is a line list ready from the base, like the ASHA in collaboration with A&M and CHO. They will do the clinical breast examination where they will find some abnormality, dimpling, puckering, whatever, We call it Punjab Artificial AI Digital Breast Cancer Screening Program. AI is for Artificial Intelligence, AI Digital, Punjab AI Digital Breast Cancer Screening Program. So, we started with Mohali on 15th of June. And we found 3 people out of, who were suspected, and I think 2 had come with malignancy. Ma'am, we did it for, I think 15, 20 days. There was camps, it was station. It's not like that, ma'am. It was just it's a population-based screening program. So, it's not, the team keeps moving. It has to cover all Punjab. So I said 89 facilities in all we are covering. That includes 23 district hospitals, 41 sub-divisional hospitals, and the rest of some of the selected CHCs, covering all of the Punjab, all regions. So we may be doing it, in another phase 2 after the results of the phase 1, but then it may become a regular feature at some of the healthcare facility, maybe at a district level. So then I was talking about the cervical cancer component, and we have done a capacity building. We are using WHO 90-70-90 formula, mandated by WHO for cervical cancer. The cheapest method is via visual inspection with acetic acid, and that's we are promoting and doing capacity building. And we did all the capacity building of our gynecologists at district hospital. And now we done a TOTs for staff nurses also, and as a team they would be imparting training to CHOs and augmenting the capacity of the ANMs also. ANMs have been earlier trained. Yeah, we did it in 2 districts, Bathinda and Mansa, as a pilot. We are doing that, and because it was expensive. HPV vaccine is a very expensive one. We were importing it. And now, since the country has made its own vaccine, that's Kyau HPV, you are aware maybe, So this is going to be rolled out probably as a part of the UIP program itself, and then we'll be adopting to other districts. COVID vaccination had taken, some of the vaccination programs strength involved in for last 2 years, last 1.5 years. COVID vaccination was quite focused. Now it is faded off because people are not coming up for COVID vaccination. So we'll be back to other routine vaccination programs. We had a special initiative for blood pressure measurement. We have what we call Army blood pressure apparatus, which promote, we have all the SDH and district hospital. Anyone can just put in his hand, arm, not hand, arm, and his blood pressure will be, recorded there. So this is a unique initiative by the state, so that makes you aware. It gives you the exact, on the spot, without any help of any paramedic required. We do a lot of IEC activities. We made a special chitti for our beneficiary. I will not call beneficiary, the people who are having diabetes or NCDs, especially for 2 letters we designed for hypertension and diabetes. These letters will be distributed, signed by the health minister, that you have to do this, eat this, not eat this, do this, don't do this. So focused, do's and don'ts, on the letters signed by the health minister were distributed to the through the ASHA and the ANMs to the people in the villages. This was unique, because usually we do print the material in the newspapers or pamphlets are posted, which are not. This was given to them by hand as a letter, and we call it chitti. I'll not take time no more. Thank you. I understand the constraints of time. I have also to go to Chennai tomorrow. Chennai was made aware about the happy streets. I saw those happy streets, really happening there. There is no traffic, and people walk. And this is unique. I intend to do it as a pilot in some cities in Punjab. Look forward to it. In fact, tomorrow I'm going to Chennai only. Thank you, everyone, for patient listening.
So, thank you, Dr. Sandeep. So, I may let you know that Dr. Sandeep is one of the most proactive nodal officers in Directorate of Health Services, and I have been working with him when I was in Punjab government. So, thank you, Dr. Sandeep. And he has told us about the new initiative that they have used artificial intelligence for screening of the breast cancer. So, thank you. So I also welcome Dr. Ravinder Khaiwal. He is with me. He is professor in School of Public Health, Department of Community Medicine, PGI. And he'll be talking about air pollution and NCDs. So maybe after the CSOs, so I'll request Dr. Ravinder to talk about it. Thank you.
Next, I would like to introduce Ms. Upinder Kaur. Ms. Kaur is Director Programs of Generation Savior Association. I request Ms. Kaur to share her perspectives as a civil society organization representative on multi-stakeholder engagement and role of CSOs in effective management of NCDs. Ma'am, please.
Thank you so much. First of all, I would really like to congratulate Hriday and Sipher for this wonderful initiative. We all know that, in the state of Punjab, NCDs is one major issue which is cropping up, and in the previous speakers also mentioned that how from the communicable diseases we as a developing nation are moving towards this issue of NCDs and how it is increasing. And even in the last 2 years during the COVID times, we've seen that we cannot actually independently see NCDs in communicable diseases. The people living with NCDs were more prone to the effects of the communicable disease, the coronavirus that came with the COVID-19. So, sticking to the topic and sticking to the time, when we talk about civil society organizations, many of us are sitting here, and I think every individual, how I define civil society organizations is not, some formal organizations working under some constitution or framework, but I think any individual in the society who wants to give back or have that knowledge or that capacity wherein that he or she can empower the other person in the society is a part of civil society. So I think the guidelines say it all, that, what all are the roles of civil society organizations. And, fortunately, unfortunately, we've seen very less professionalism when we talk about formal NGOs. Like, when we also go to government departments or other departments, when we introduce ourselves as NGOs, the definition of NGOs per se is taken very negatively at times, because it is usually associated with more of activism and, fighting against the governments or something like that. So I think one very important element that comes here is that, that narrative needs to be changed. That narrative should be that, we are here to work with the government for the betterment of the society. So that message, the difference of understanding with the institution should be very clear, because that's where the government departments will have trust on us in actually giving us the responsibility of these such important programs that the states are running. Because every program does have an element wherein, the government of India has outlined what a role of a civil society organization or an NGO will be. But we see very less formally, very less NGOs actually formally working on these programs with the state departments. Yes, like we've been working in tobacco control, we've been working very closely with the state tobacco control cell. We've worked when Dr. Gupta was the nodal officer. We've also worked with Dr. Sandeep Gill when he was, for a brief period of time looking after tobacco control, and tobacco control being on the #1 for NCDs also. So, but then when we talk about it, we have been supporting them. We've also been trying to, in the state level, trying to get the other organizations working on different levels, in different programs and different levels, to come as a common voice for all these NCDs. So we've spoken about the Safe School programs, we've spoken about other programs. So we really need to first, I think very important part is mapping of all these organizations and people who have these, because every so like if we talk about our organization, the thing that lies in our heart is youth intervention programs and tobacco control. Yes, we do talk about NCDs, we do talk about gender issues, we do talk about other issues, but then every organization and every individual has that one cause which is like the heart of their existence. So we really need to identify them and then reach out to them also, because capacity building is not needed only from the CSOs to the government departments for the programs, but maybe it's the other way around also. We really need to sensitize the other civil society organizations working in different areas and, trying to convince them that, it's better to join hands and work collectively, because in the end, the goals are the same. Any organization working in any of the public health programs, their ultimate goal is saving lives of, whatever program that we spoke about. So looking forward to the guidelines, sensitization, yes, working with the government and not against the government is one message that really need to go out to the civil society organizations also, that it is not always trying to find out faults in what is lacking, because we have some beautiful programs, we have beautiful policies, but where we lack is that awareness. So if today, the people sitting in this room and virtually joining us, I'm sure there were many programs, there were many initiatives in the state, we working with the health department, we were still unaware of them. So we can imagine that, the people who are nowhere related, professionally to these programs or these departments, they don't even know that these programs exist and the government is providing them. Like as Dr. Gill said about the artificial intelligence of screening breast cancers, I wasn't aware of it, that Punjab is going forward in that direction also. So it becomes very important to, kind of decentralize and move this information lower in the hierarchies also, so that it doesn't stays within the rooms. And I think that is the most important role of the civil society organizations. And thank you. And also generating evidence, because at times, so how a disease is understood by a doctor and by a layman. So I'm a layman in public health. I don't have a medical background. So I really don't understand diseases the way, the doctors understand. But being from the civil society organization, working in the development sector, working in the public health, I think what I can give back to, or people like me can give back to, is what people facing those difficulties and people working to overcome those difficulties are facing. So those evidence generation becomes very important for the policy formation. And one thing which is, very close to my heart is that, at times when we also kind of get those datas, intentionally or unintentionally, we generalize the data a lot. So NCDs for males and females are two different parameters. So NCDs for upper middle class families, the lower middle class families, and the BPL families are different. Even how we define those diseases and how the difficulties are defined. So whenever we're trying to create evidence, and especially in forums like these, I think focused interventions is one thing that we really need to now start moving ahead rather than with just generic policies. You know, in public health, I really don't think so that one size fits all. We really have to, you know, kind of develop and rework on those policies, and also the implementation of those policies need to be reworked on. So that's it from me. So thank you so much.
Thank you so much,
Thank you.
ma'am.
Vidar, please stay for the release. Welcome Professor Dr. Thakur. So he's our guest of honor. So, so we are thankful to you, sir, for joining. Thank you.
Next, I would like to introduce Mrs. Renu Sehgal. Mrs. Sehgal is President of Shahayata Charitable Welfare Society, an NGO working for cancer patients, and she herself is a cancer survivor. I request Mrs. Sehgal to share her experience and valuable viewpoint with us from the lens of a person living with NCD as well as a CSO representative. Ma'am, please.